Hi, everyone. Besides the fact that you read the name of this lecture before you opened it, does anyone have an idea why Bernice is dressed like this? That's right. This is a compression suit. These are soot marks on my face. That means we will be discussing burns. Thank you, Bernice, for bringing this information today. You're welcome. Now let's get started. I want to tell you that burns are very serious, and they're even more serious, and the risk for death increases with the very old and the very young. Why? Well, the very young have an increased body surface area, so when they get burned, it's going to take up a larger part of their body and damage more. The very old have a decreased amount of sub-Q fat, so that burn is going to come through and it's going to go deeper, faster. Most burns occur at home, and that is why we as nurses need to teach our clients, make sure that your hot water heater is turned down to at least 120 or lower, especially if you have older people living in your home or younger children living in your home. Now, let's talk about the pathophysiology of a burn. The main thing I want you to know, very important, is the very first 24 hours this patient is in danger of shock. Let me tell you why. The vessels and the cells are damaged from the heat. It causes the plasma and everything in the cells to seep out. It causes edema. Now, it's great. The amount of edema can be great. It can actually cause us to be hypovolemic. Now, that's why anytime you get a burn, just say you get a small burn on your hand and you get the big blister, that's edema. That is fluid from other places coming and being somewhere that it should not be. So if you have a major burn, you're going to have a major fluid problem. Now, this increased capillary permeability causes things to seep out and be where they're not supposed to be. The majority occurs, like I said, during the first 24 hours. That is a critical time for shock. Our pulse increases because we are in deficit. And when we are in deficit, our heart is taking what little bit of fluid that it has in the vascular space, because we've lost most of the vascular space because it's in the interstitial space, and it's trying to get it circulated around to where it needs to be. Our cardiac output is going to decrease. Less volume to pump out. That means our urine output is going to decrease. Okay? Now, the kidneys are either trying to hold on to the fluid that they have, or they just don't have enough coming down to perfuse them. Now, this is very dangerous. We are burned. We are at risk for infection. We are probably going to have some surgery. I don't want the kidneys involved. I don't want to be in renal failure. So it only takes 20 minutes for permanent damage to happen to the kidneys. We have got to keep those kidneys to be perfused. And I'm going to tell you what and how in the medical field we're going to try to help with this concerning a burn victim. Now, epinephrine is secreted. It's that flight or fight thing, right? It's a normal stress response. The epinephrine's excreted. It causes us to constrict and actually shunt blood where it needs to be. The brain, the heart, the kidneys, right? We need more blood there than I need in my little fingertip right now at this moment, okay? Now, ADH and aldosterone are going to be secreted. Why? We need to retain what little sodium and water and fluid we have. So ADH and aldosterone are going to come in. They're going to signal for the kidneys to, hey, don't let anything get past you here. Okay? That increase in the water and that increase in the sodium is going to cause the blood volume to go up. Therefore, we're going to have a little bit more to work with, right? Now let's talk about airway injury for a moment, okay? The most common airway injury is going to be carbon monoxide poisoning. And let me tell you what happens. We know that our little oxygen combines to our hemoglobin, right? On every hemoglobin, there's 4 places for that oxygen to bind, okay? But CO2 is quicker, okay? CO2 is quicker, so it actually gets to that it actually gets to the hemoglobin faster. So what do we need to do to somebody that has had carbon monoxide poisoning? We need to put 100% oxygen non-rebreather mask on their face so that we can be pumping in as much oxygen as we can to give maybe a better chance for that oxygen to get attached to some hemoglobin, because we don't want to become hypoxic, okay? And that's what happens when all your CO2 is attached to all your hemoglobins, right? Now let me tell you, the little finger probe that tells you the stat on your oxygen, it might read 100%. Why? Because it's just measuring if there's something attached to the hemoglobin, and it is. There's carbon monoxide attached to the hemoglobin. That doesn't know that it's not oxygen. So it might read 100%. Now, the treatment for this, like I said, is to give 100% oxygen to help with the race here. Now, do you think that from this information, it would be better to have an inhalation injury in a closed room or a wide open space? Okay, Bernice, we're not stupid. That's right, I know you're not stupid. It would definitely be better to have this occur in an open space. A closed space is going to have more chances for us to breathe in more of the toxic chemicals, right? Now, anytime you see a client with burns to their neck or to their face, we need to think airway, okay? Now let me tell you, remember what I said happens in the first 24 hours? We start to swell and swell and swell and swell, okay? It gets worse and worse and worse before it gets better. So, if your patient is laying there fine, can breathe fine, does that mean in 20 minutes they'll be breathing fine? No, not if they have an airway problem, not if they've gotten burned in their airway. The doctor might prophylactically do an artificial airway. Do you think they're going to trach this person? They might trach the person, but first, before it happens, before we have to go as far as doing something such as a trach, let's go ahead and put an oropharynx tube down, okay? Because I can pretty much, once it's swollen enough, you're not getting it down. Then you are going to have to trach it, okay? We're going to have to intubate, probably prophylactically, okay? But let's always try the least invasive first if we can do that. The main thing that I want you to know here as a nurse is that you've got to stay on top of the airway. You've got to stay on top of the fluid volume, okay? We got to stay on top of the renal failure, okay? We don't want to trach if we can just regular intubate through the mouth, right? Okay, now, let's get back to the burns. There is a way to do a quick general assessment of the percentage of body surface area that has been burned. And this is called the rule of nines. And I tell you, self-explanatory, easy to remember, okay? It's called the rule of nines because everything calculated is a 9 or a multiple of 9. Now let me tell you what I'm saying here. The head, guess how much? 9%. Okay? An arm, 9%. The other arm, 9%. The leg, 9%. 9%. Matter of fact, the only two things that aren't 9% is the front side of the chest, which is 18%. And then the back side, which is 18%. Okay? Now, we've got your growing area. It is 1%. I don't care who you think you are or what you think you have or don't have. Everybody is counted. 1% right there, okay? So, fairly simple to remember. Everything is 9 except for the front of the chest and the back of the chest, right? Great. In the growing area, 1%. Don't try it. No, 1%. Okay, now, we're going to talk about clients that have a fairly large amount of their body surface area burned, 20 to 25%, okay? Our number one goal, thought, everything we're leaning towards right now is fluid volume replacement, okay? It's one of the most important aspects of burn management. We've got to get these fluids back in these people or we are going to have major problems, okay? They've got the fluid in their body, right? It's just in the wrong places. It's not in the vascular space. And that's what we're worried about, is the vascular space. Now, we have to know when the burn occurred, okay? We have got a formula called the Parkland formula. And it's based on the first 24 hours of when the burn occurred. Not when they got to the hospital, not when they first started getting their fluids, but when the burn occurred, okay? So what we're going to do is we're going to take 4 milliliters of lactated ringers multiplied by their body weight in kilograms. I like kilograms because it makes me way smaller when I say, you ask me, how much do you weigh? I'm going to say, oh, I weigh like 46 kilograms. That's right. Always remember, kilogram is smaller than the pounds. So you divide the pounds by 2.2. Now back to the formula. 4 milliliters times the patient's body weight in kilograms times the percentage of body weight burned. So, the percentage of body burned, body surface area. If their body surface area burned is 40%, you multiply it by 40. So, let's use that right now. Let's say that our patient, we're going to do 4 milliliters times 65 kilograms times 40. Okay? That is our total amount of fluid we're going to give in 24 hours. Okay? 4 milliliters of lactated ringers times the kilograms of that person's weight times the percentage of body surface area burned. Use it as a number, not a percentage. 40. Just multiply it by 40 or whatever the percentage is. Okay? Now we're going to break this down into 3 phases. During the first 8 hours, we want to give half of it, okay? So say that our number came up with 100 milliliters of lactated ringers. So the first 8 hours, I want to give 50 milliliters, okay? Now, what if the person came in an hour after they got burned? Is that when I start my time? No, I start my time, like I said, when they got burned. So, now, instead of having 8 hours to get in my 50 milliliters, I've got 7 hours, okay? Now, the second 8 hours, I'm going to give 1/4. And the third 8 hours, I'm going to give 1/4, okay? So, during those 8, 8, and 8, 24 hours, I've given the complete amount of the fluids that are very necessary to keep this patient going. We don't want renal failure, okay? Now, I just want you to know that our main thing here is going to be urine output. Yes, when we think about fluid volume excess and fluid volume deficit, we're thinking of daily weights and INOs, and daily weights and INOs are good if you're looking at increases and decreases over certain periods of time, but in this point, we're going to choose urine output. And for a burn patient, urine output should be 30 milliliters per hour, none less. Anything less, they are going to be in danger for renal failure, and we don't want another problem added. Now, in emergency management, we run up onto a fire. What do? We're going to take that person and we're going to wrap them up in a blanket, okay? Now, does that blanket keep the burning process from happening? No. They're still burning under the blanket. Damage is still happening. We could actually, if the burn is not huge, maybe apply some cool water on it. That would help with the burning process, but I want you to make sure you don't throw cold water and think the colder the better. Hey, colder, better. No. Bernice says no. Okay? Cold water causes us to vasoconstrict. Now you've really just reduced the blood flow to the area, okay? Cool water. That blanket actually does help by holding in the body heat, okay? The body temperature. And also keeping any germs or bacteria from getting into their open wounds. We need to remove jewelry. Why? Jewelry gets hot. It's going to burn for longer. Why? What is our number one problem right now? Swelling. It might be so swollen we can't get the jewelry off, okay? So remove the jewelry. We need to remove any non-adherent clothing. If it's stuck on there, please don't try to rip it off. Leave it. Cut. Get the clothing off. Now, signs of airway injury. Say, the fireman just pulled somebody out of the house and they've got major burns to their arm and they're burned over on this arm, but you notice that they've got soot on their face. You notice that their nasal hairs are all singed and it's got that nasty hair singed smell. Maybe they have blisters on their mouth or on the inside of their mouth. Or they're trying to cough and you notice there's little black specks in their sputum. These are signs that they have upper airway burns. You might not be able to look in there and see anything right now, but believe me, within 24 hours they're going to be swelling. To what extent, I'm not sure. Different strokes for different folks, but they will be swelling. You as a nurse need to be watching swelling and urine output right here, right now, okay? Now, more deaths occur because of upper body burns. Go figure. Thanks for that tip, Bernice. Now, they're not breathing as much, okay? They've got upper airway problems. They're not breathing as much as they should. What are they retaining? That's right, CO2. Now, if they are retaining CO2, they can go into respiratory acidosis. Come on, no, nurse, we're watching for this. We got to be careful because we don't want some acidosis going on, do we? No. Okay, now, let me tell you about some medical management for burn victims. First is going to be some albumin. Okay, albumin, remember, helps to hold the fluid in the vascular space. It increases the vascular volume. It increases the kidney perfusion. It increases the blood pressure. It increases the cardiac output. Okay? We're putting more fluid into the vascular space. Increase also increases the workload on the heart, right? So we got to be careful about the workload on the heart. We don't want to stress the heart too much, do we? So let me ask you this. I'm going to ask you a question, and I want you to give me an answer. If a client who is receiving fluids rapidly, what is a measurement you could take hourly to ensure you're not overloading the client? Ding, 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 ding. That's right. That's absolutely right. Central venous pressure. Good answer. Good answer. Remember, it goes in, it sits in the right atrium of the heart, and it is a very accurate measurement for the pressure in your right atrium. We don't want to overwhelm the heart. Okay, now pain management. This person is going to be in pain. They're going to require pain medicine. Please remember to give the least amount of narcotics necessary to relieve the pain. On the bell, you've got a PRN for 2 milligrams or 4 milligrams of morphine. Please don't run in there and just pop them with the 4. That would be nice. I would like to have 4, but our goal is to remember to give the least amount of narcotics to relieve the pain, right? Now, we want to give IV medicine through the IV, not intramuscular, okay? Those muscles, we got to have a good muscle. For the medicine to be absorbed, IV works faster, IV's better. Okay, now let me tell you about immunization real quick. These patients will need to have a tetanus shot, especially if we don't know when their last tetanus shot is. Now, I give a tetanus shot. This is active immunity. It's going to take the body 2 to 4 weeks to actively build up immunity to tetanus, okay? So, what about now? Well, I'm going to give you an immune globulin. Anytime you hear the word immune globulin, I want you to think of now, baby. I didn't have to work for it, but I got it. It's passive immunity, and it goes into effect now. Now, it doesn't last long, but it will give me what I need until I can actively do my own, okay? It's immediate protection. Now, complications, the circulatory system, okay? Say you get a circumferential burn all the way around your arm, okay? What are some really bad things that we need to be watching out for? Well, we definitely don't want it to swell, have compartment syndrome, cut off our circulation. No, we don't want nerve damage. I'm going to tell you that. Remember, we're trying to keep down as many bad other things from happening. We're already burned, okay? So, as a nurse, if they are completely burned all the way around, I'm going to be going in and I'm going to be checking the pulses, the capillary refills, the temperature, the color of their fingers to make sure that circulation is happening, okay? Now, what if it's not happening? What if they do have pressure? What if their fingers are turning purple, okay? The doctor's going to come in and do an escharotomy, okay? Now, that escharotomy is going to relieve pressure and restore circulation, and it just cuts through that old black nasty eschar, okay? Or, worse is a fasciotomy, okay? Now, fasciotomy does the same thing. It goes in, it relieves the pressure, it restores the circulation, but the cut is much deeper. It goes through the eschar and the fascia. Fasciotomy, okay? So, eschar starts with an E. Fasciotomy starts with an F. If I had to choose between the two, I'd rather have the E than the F because it's a less deep cut. Okay. The renal system. A catheter is going to be put in. Why? Please tell Bernice that you know why these people will have a Foley catheter. We are measuring that urine output. We are watching it like hawks. We are good nurses. We are on top of our game. And we are watching that urine output every hour, and it better be 30 milliliters. It better be. It better be. Okay? Now, if we put that Foley catheter in and no urine comes out, is that normal? Well, yeah. They might be in shock. Their kidneys might not be getting enough. They might not be perfused, or they might be holding what they got. Thank you, ADH and aldosterone. They might be holding what they got to try to keep all the fluid that they can inside. Now, if you do start to notice some red or brown stuff in that urine, what do you need to do? Please, promise me you're going to call the doctor. Bring. I'll tell you why. Because that shows that the person is having some breakdown of muscles, and there's some myoglobin and some other stuff that's getting in there. It's passing through the urine. That spells kidney problems, okay? We do not want kidney problems. The doctor might order mannitol to help diuresin get some of that out, but I'm going to tell you that's his call, because diuresin, an already fluid volume deficit person, gonna be tricky right there. Gonna be tricky, but I don't want renal failure. Okay? Now, if there is not urine output, or if it's less than 30 milliliters an hour, what am I, as a good nurse, going to worry about? Renal failure. Hey, shock, renal failure. I'm worried about that right here, right now. Okay? I hope that you're getting this in your noggin. Now, after about 48 hours, the patient has swollen and leaked and done everything they're going to do, and guess what starts to happen? That's right, all that stuff that leaked out is now going to start coming back. I want to come back. I want to come back. I want to be where I'm supposed to be. Well, thank goodness. It's about time. The only bad thing now is, now your patient is going to be in fluid volume excess. Now we've got to be careful for the second side of that coin, right? Everything's coming back into the vascular space. Input, urine output is going to be greater now. You're going to start to see it coming on out now, coming on out. Okay? Now, let me just ask you this. When all of our cells got disrupted and they started lysing and leaking, what is one thing in the cell, when it leaks out, we really need to be worried and concerned about? Potassium. That's right. The normal potassium value is 3.5 to 5.0. With all the cell lysis that's going on, our potassium is going to leave the cells, get into the intravascular space, and could cause hyperkalemia. Okay? Hyperkalemia has a set of problems all on its own. So now, I don't want stuff happening to my kidneys. I don't want stuff happening to my brain. Okay? Just know, expect hyperkalemia. Do what it takes to monitor these electrolyte imbalances, the urine output. Okay? Now, the GI system. This person is actually going to be on some Mylanta, some Protonix to prevent, I know, Bernice, I know, stress ulcers. Right, little prodigy child. Stress ulcers. Also called Curling's ulcer. Why do you think the doctor wants this patient in PO or have an NG tube hooked to suction? I know, Bernice, because we don't want paralytic ileus to be formed. It could already be developed, and that's why maybe some suction is going on, okay? All the blood has been shunted away from the minor organs like the GI tract to put it to where it needs to be more, okay? That's just a normal stress response. Now, if the client does not have bowel sounds, do you think the abdominal girth is going to be bigger or smaller? Bigger. You're so smart. Now, do you think that this person is going to need more calories or less calories? More. They're in a hyper-metabolic state, and they are going to need maximum nutrition. And when I say maximum nutrition, I want you to think of protein and vitamin C. Okay? Now, when can we take that NG tube out? When we hear bowel sounds return. Yay, bowel sounds. And all four quadrants would be great. Now, let me just say this. You're going in, you're checking the gastric residue, okay, residuals. And you got an order that says, hey, don't give any more food through that tube if they have, say, 70 milliliters of residual. So you take your syringe and you suck it out, and it's all, I mean, like, looks like something off the Teenage Mutant Ninja Turtle green, okay? And, yep, they've got more than 70, gonna have to hold that tube feeding. What do you do with all that gastric stuff? Chunk it in the garbage? No. You're a good nurse. You don't want anything bad to happen to your patient. You're going to give it back to them. They need it. That's got fluid and electrolytes and all kinds of good Teenage Mutant Ninja Turtle stuff they need in their body. Okay? Now, I got a question for you. If you're going to test your client's nutrition status, you can test the total albumin, pre-albumin, you can test total protein. What do you think is the most sensitive of those three? Pre-albumin, total protein, or albumin for a nutrition? Pre-albumin. Pre-albumin is the most sensitive test for a nutritional status, okay, on your patient. Now, when the patient finally does start to get better than where they're at now, and I really want you to be concerned for contractures, okay? It's especially dangerous with third-degree burns. If they have been burned on their hand, what do you want to do when you wrap their hand? Thanks for the hint, Bernice. That's right. You want to wrap their fingers individually. Please don't be the nurse that gives them a web hand, okay? Please. Common sense here, people. Don't set them up on the pillow at night if they've been burned on their neck and now they got the contracture, okay? I think that most people know to keep your chin up. Chin up loud, especially if you've got a little extra fat down here. The more you move your chin down, the more you get that double chin, don't you? Now, I know somebody, and I don't know why she does, but she's always got her face like this, and it's got this big roll, and she's really skinny, but gosh, she's got the roll. Anyway, okay, I'm sorry. Don't let them sleep on a pillow. We don't want a contracture of the head. We've got to think about contractures. We've got to splint the fingers so one of them's not down, okay? We got to wrap them individually. We can't let them sleep on pillows. If they have a perineal burn, what do you think's the most important thing to be thinking here? Infection. That area is just not always, okay, seriously now, it's not always clean just due to the nature of what's going on down there all the time, right? Okay, so infection is the number one thing. Let's watch out for that. Now, eschar is dead, black, nasty tissue that bacteria loves to live in, and all eschar must be removed before new growth can occur, okay? New growth cannot happen, it cannot regenerate if that nasty eschar is there, okay? Now, these patients are going to be in reverse isolation. I don't want to give the patient something, okay? Now, most of the time you think of isolation is you don't want to get something from the patient, but right here, we don't want to give the patient something, okay? Because they've got enough going on with their open wounds. Now, we can use Travase or collagenase, and these are enzymatic drugs that actually eat the dead tissue. You put them on there, and they just start eating away at dead tissue. But please don't put these things near a body cavity, okay? Because this stuff can actually like climb up into the body cavity and start eating internal organs. Ooh! We don't want to cause our burn patient more problems. No renal failure, no organ eating going on here, okay? We also don't want to put it on their face. It will scar horribly. We don't want to give it to pregnant women. We don't want to rub it over a huge nerve like the sciatic. We don't put it all the way up their back and all the way down, okay? Kind of really can't. Got to be careful with this stuff. It's some potent stuff. Now, also, these patients might go to hydrotherapy, and this is used to debride the wounds, okay? And they get in this whirlpool, and it helps debride the wounds. The only thing with this is you might have one type bacteria over here and one type bacteria over here. So in the whirlpool, there's a lot of cross-contamination going on, okay? And that's the number one problem with that. But let me tell you, this whirlpool is not like me slipping off into my jacuzzi at night. Ooh, feeling all good. This hurts. So please make sure you give your patient enough good pain meds so this is not painful for them. Now, some common drugs used with burns is Silvadene, sulfamylin, silver nitrate, and betadine. You can see those, expect to see those. These drugs are going to be shuffled up and mixed up, and one given here and one given there and one given here. And that's really just due to trying to keep the bacteria's resistance and the tolerance buildup down, okay? Broad spectrum drugs will be given at the very beginning, but we don't want to create a super infection, do we? Or a secondary infection. So we're going to take cultures of the wound. We're going to start them on the broad spectrum antibiotic. As soon as that culture comes back and lets me know what's going on and what that little invading microorganism is invading my patient, I'm going to start them on the correct antibiotic, and I'm going to take them off that gentamicin that would kill anything and everything, right? Plus, anytime you see those mycin drugs, you better watch out. I want you to measure that BUN and creatine all the time because it causes renal problems. Not only that, autotoxicity, and if your patient, if you go in there and they say, I hear like ringing, stop that medication ASAP. It might not be that, but we're going to assume the worst, right? Okay, so I want you to always, if you see a little tiny rise, just a slight variation in their BUN or creatinine, please just assume that that patient is nephrotoxic and stop that mycin right in its tracks, okay? Now, last but not least, we're wrapping it up, thank goodness, short but sweet. Going to finish it up right here. Grafting, okay? You cannot put a graft on an arm until that arm is completely free of any nasty, burnt, dead tissue. Has to all be taken off before you can put the graft there. Now, good skin can be taken from another donor site and put on the bad side, okay? But now, remember, you've got two wounds now. The good donor site can be covered with just plain transparent dressing, so you'll be able to keep an eye on that. And you know what I think is so cool? If our patient is in the nutritional status that they need to be in, I can come back to this donor site in 12 to 14 days and get some more. Yes, your body does what it needs to do to fix itself to where you can actually come back in and get reharvest from that area. Okay? Every 12 to 14 days. Now, should the site, say you slapped your piece of skin on here, should it become blue or discolored, you are not getting good perfusion, are you? Should it be like all kind of hard and crusty like it's drying up? That's not good perfusion. You need to call the doctor and let them know what's going on. Your doctor also might get you to take Q-tips and roll them gently over that skin graft to squeeze any junk that's building up underneath there. Squeeze it on out so that your skin graft will have something to adhere to and all that nasty gunk's not happening in there. Now, the last thing I want to tell you about are chemical and electrical burns. There's just a few things, a few high points that I want to hit on about the chemical and electrical burns, okay? Now with the chemical burn, first you need to remove the client from the chemical or the chemical from the client. If it is a powder, we need to brush as much of that chemical as we can off. If it's a liquid or anything else, we need to do whatever it takes. Now if it is a chemical burn, I want you to flush the client with copious amounts of water for 15 to 20 minutes. I'm telling you, you stand there and you flush and you flush and you flush, okay? You need to remove their contacts. You need to remove their glasses. Now with electrical burns, you've got two burns. You've got an Bernice, calm down. You have an entrance point and an exit point, okay? The first things with electrical burns that you really need to be thinking of is cardiac, because all this electricity going through the body resets the heart. It causes you to have arrhythmias. VFib is the highest risk arrhythmia that we are concerned about here. Okay? Now, with electrical burns, also, myoglobin and hemoglobin are released, and they can build up and clog the kidneys. Here we go again. Let's please protect the kidneys, okay? We're really going to be watching for this. They can cause kidney damage. Now, expect to see the client on a spine board with a C-collar on if they've had an electrical burn. Why? Because most electrical burns occur up high. Chances are the patient fell during the process. Okay? That's another whole risk for injury in itself. Not to mention that the electricity causes muscle contractions that can actually break bones because they are contracting so much. Okay? So we've really got to be worried about that. Amputations are really common with electrical burns because that circulatory system is just so damaged that there's really sometimes nothing that can be done about it. Then the last thing I want to let you know are that other complications with electrical wounds could be, or other complications of electrical wounds could be cataracts, gait problems, and just about any type of neurological deficit. Okay? So please remember, keep the fluids going. Watch the fluids coming out. Watch for infection. Be a good nurse. Bye, class. Bye, Miss Bernice.